Hey guys, it's Gianna, Midwifay. Today, for the second installment in my induction of labor series, I wanted to talk about being induced for being overdue. What does it mean to be overdue? How do we calculate due dates? What are the risks? What are the benefits? We're going to get into it. All right, let's go. Always, I want to encourage you, please like this video, subscribe to the channel. It really helps me know which videos you guys like and what other content you want. So please go ahead and like and subscribe if you haven't already. All right, so first let's talk about this due date, the illustrious estimated date of delivery. That's what EDD stands for. How do we even calculate that, okay? So your due date is calculated a few different ways. Kind of one of the most common ways to calculate your estimated due date is to use Naegele's rule. What that is looking at the first day of your last menstrual period, subtracting 3 months from that month, and adding a year and adding 7 days, and that's your due date. That's based on calculating based on a 28-day menstrual cycle and based on an ovulation day around day 14 in there. So that is Naegele's rule. It's kind of the old school way. It's what all of the apps, all of the estimated due date wheels, that's what they use, is Naegele's rule. So it's super important to know for you, for your pregnancy, how is your pregnancy dated, right? So knowing your body, do you have regular menstrual cycles? Are they 28-day cycles, 26-day cycles, 42-day cycles, longer, shorter, right? That's going to change when you ovulated and therefore when you conceived. So Naegele's rule alone, using the apps, using the wheels, cannot really apply and be accurate for all people. Because of how potentially inaccurate this can be, we compare this estimated due date we get to the first ultrasound that we ever do, right? So we know that the earliest ultrasounds, really that first trimester ultrasound, anything less than 12, 14 weeks, is pretty accurate in telling us your due date. We measure something called the crown rump length, which is the measure of the tiny little baby, the embryo at that point, from the crown to the rump, really, and that tells us the estimated gestational age. So we often compare that to the estimated due date we have from your period or from using that Naegele's rule and see if they are off by a certain amount, then we will go by the ultrasound date because that is more accurate using that measurement. Some other scenarios where we do an estimated due date that actually is more accurate would be assisted reproductive technology. So if you got pregnant via IVF or IUI, those are actually really accurate due dates that we get because if you've gone through those extensive processes, you know all of the medications and regimens and everything that we've been doing to kind of prepare the uterus for the embryo, for the sperm, and then the exact conception date is known in those cases usually. So whenever a due date is based on assisted reproductive technology, that's actually the most accurate. And then for most all the other cases, we look at that first earliest ultrasound, that first trimester ultrasound to give your due date. Once we have the due date calculated, we use that to determine your estimated gestational age. So your EDD, your due date, is 40 weeks and 0 day. So every day up until that is a different gestational age. So it's super important for you to know for your pregnancy, how is this pregnancy dated? Did you have an early ultrasound that matched a period date or was it different? Were you nursing a baby and hadn't had a cycle in a year and a half? And so you don't really know what it was and then you had an ultrasound and it said you were about 16 weeks? Do you have super irregular cycles and you kind of guessed and all your ultrasounds kind of have been ish around this time, right? So it's really important for you to know when making a true informed decision about whether you're going to proceed with induction based on definitions and risks that we're going to go over soon. What was my due date calculated by and how accurate is that for me? So now that we've gone over how we calculate due date, let's go over some definitions that I'm going to use throughout the remainder of the video in order to determine kind of risks and recommendations at those points, okay? So I think a lot of people say, I'm overdue, and really we don't know the correct terminology. So here is the definition of the correct terminology at the end of pregnancy. Now that we know correct terms, we can all use these definitions as we move forward. So when you're talking about being induced, is your OB recommending induction at 40 weeks for being overdue? Are they talking about this 39-week induction that I have another video on, and I'm going to do a second version of that video soon, right? Or are they talking about induction in that 41-week to 42-week mark? I should say for this video, I am talking about low risk pregnancies, okay? So not having any other medical or obstetric complication up until this point. So I'm talking about an induction strictly for the reason of being over your due date, not any other reason at this point. So if that's the case, if you're a total low risk pregnant person coming to your due date and maybe getting past that 40-week mark, what are the risks, okay? The biggest risks that we'll talk about are hypertensive disorders of pregnancy. The longer you stay pregnant, there is an increased chance of gestational hypertension, preeclampsia, so that can happen. The risk of a bigger baby. The data shows that baby size starts to increase more dramatically after that 38-week mark. So as baby gets bigger, there can be risks, but go watch my big baby video. Hopefully that sheds some light on those potential risks. Some other risks that we look at are meconium stained fluid. Meconium is when babies have a bowel movement inside, so the water, the amniotic fluid is not clear, it's more like green or brown. It in and of itself isn't a problem, but a handful of babies that are born with meconium can inhale that fluid, which might cause some respiratory issues with adjusting to newborn life. So meconium stained fluid, we know that that risk increases as the pregnancy progresses. NICU admission rates increase, as well as low 5-minute APGAR scores increase as pregnancy moves on. And those rates significantly increase kind of at the end of the 40-week in the 41-week mark. I would say, other than those risk factors, the biggest risk factors that people truly consider and why a lot of OB providers recommend induction when they do is because of the risk of stillbirth, which is obviously the most devastating and horrible outcome for mom and baby. The risk of stillbirth does increase as gestational age increases. However, the overall risk of stillbirth in a low-risk pregnant person is still significantly low. I have the chart here of the increase in rates of stillbirth and kind of when that risk jumps significantly, which data strongly supports is in that 41st week of pregnancy. So how many people go into labor spontaneously by their due date? There's a lot of different studies that go over this, and there's not a lot of good data. What we know is about 10% of people go into labor on their own by 39 weeks, but 50% of people for the first time go into labor on their own if allowed to wait until about 40 weeks, 5 days. And over 50% of people that have given birth before will go into labor on their own by 40 weeks and 3 days. So that's kind of the best aggregate data we have. No one has a crystal ball to say, you're gonna go into labor then, you're gonna go into labor then. We just don't know. But there's data that looks at when people go into labor and what risks are of waiting for spontaneous labor. All right, so now we have this information of the risks. What are the benefits? Benefits of waiting for spontaneous labor are that there is a cascade that happens in the normal physiology at the end of pregnancy and the initiation of labor that we just don't fully understand yet. That's part of the reason why we have failed inductions and things, because we just don't know exactly the full hormonal chemical cascade that causes labor. So there is a benefit to waiting for that to happen for your body. I'm going to put this quote that I love by Dr. Sarah Buckley, which just states it beautifully. There is benefit to waiting for the birthing person's body and the fetus's body to say that they are ready to work together to go into labor. Not only are outcomes usually better in terms of the labor, duration, experience, satisfaction, bonding, and the further cascades that happen postpartum are benefited from the normal physiologic onset of labor and birth. So what are your options? If you are being approached by your OB and recommended to have an induction for being close to your due date, over your due date, now you're empowered with the knowledge. Where do you fall in that? Are you 39 weeks? Are you 40 weeks? Are you early term, late term, Or are you truly post-term? Much more rare. I think I've seen it once in my 11 years of being in maternity practice in America. So you truly are now armed with the definitions and with the risks associated with that. Once you know that, what are your options? Your options are to choose to proceed with a labor induction as early as 39 weeks. A lot of OB practices start checking your cervix, if you allow, around 36, 37 weeks, so they can tell you, although the cervical check does not say that you're going to go into labor, but it can give you kind of a starting point as to where your cervix is to see if your body has showed any signs of being ripe and starting to get ready for labor to inform your decision. So you can choose to be induced at 39 weeks at the earliest. You can also choose for what we call expectant management. Expectant management is the theory of watch and wait, really. So it's what would you reasonably expect to happen if we did nothing? And it's just waiting, allowing time to go by, continuing to go to your appointments. Usually this involves increased surveillance for mom and baby. So you might have twice weekly appointments instead of once weekly. We likely will recommend adding some other additional tests to look at baby and mom's well-being, specifically a non-stress test, which is where they hook the baby up to the monitors and take a look at how baby is responding inside. An amniotic fluid index is counting the fluid around baby. Usually, as the pregnancy progresses, fluid can start to decline, and that can be a sign of fetal well-being starting to be of concern. So there's a lot of different tests and things that you can do at more frequent visits to keep watching and waiting while your body is hopefully preparing and getting more ripe and ready to go into labor on its own. Data strongly supports moving forward with an induction in that 41st week of pregnancy because mainly of that much more increased risk of stillbirth, as well as the other complications that we discussed. So if you have gone to your increasing appointments, doing your NSTs, AFIs, and everything is reassuring and you get to that 41-week mark, more than likely your OB is going to recommend proceeding with induction at that point. And that's when you continue to have the risk benefits discussion, discussing the steps of induction, what your options are at your facility. Okay, I hope this video helped. I hope knowing the definitions of early term, term, late term, post-term, I hope that was really informative. And I hope that empowering you with the knowledge of knowing how your pregnancy due date was calculated, if that can help you make a decision if you've got to face an induction for being overdue. Okay, that's it. I'll see you next time. Take care. Bye-bye.